In this podcast episode, Dr. Joanna Moncrieff challenges widely held beliefs about depression, specifically questioning the chemical imbalance theory and the role of antidepressant medications. The conversation explores the origins of the chemical imbalance idea, the effectiveness and side effects of antidepressants, how depression is conceptualized, and the broader implications of medicalizing emotional distress. Dr. Moncrieff also discusses the impact of pharmaceutical influences, alternative views on depression's causes, the consequences of mental health as an identity, and emerging trends in psychiatric medication, including psychedelics and related substances. Dr. Moncrieff explains that the chemical imbalance theory, that depression is caused by a deficit of brain chemicals like serotonin, lacks consistent scientific evidence. While the idea originated in the 1960s within psychiatric research, it only became widespread in the 1990s after pharmaceutical companies heavily promoted it to market new antidepressants, particularly SSRIs, selective serotonin reuptake inhibitors. Extensive reviews show mixed and contradictory findings. Some studies find lower serotonin levels in depressed people, others find none or even higher levels, meaning no clear biological abnormality has been reliably established. This myth persists on many public platforms despite a lack of support in scientific data. SSRIs are designed to increase serotonin activity in the brain by preventing its reabsorption between nerve cells, theoretically enhancing mood. Yet actual effects remain uncertain. Surprisingly, some long-term users may have lower serotonin activity. More importantly, serotonin's direct influence on mood is not well established. These drugs do cause noticeable emotional effects, primarily an emotional numbing or flattening, reducing both sadness and joy. Clinical trials show SSRIs outperform placebos only marginally, with differences so small that their practical benefit is questionable. Sexual dysfunction is one of the few side effects with clearer links to serotonin's action, often undermining patients' quality of life. The medicalization of depression as a brain disorder linked to chemical imbalance coincided with pharmaceutical companies seeking to replace older, problematic drugs like benzodiazepines with SSRIs. This framing served commercial interests by providing a simple medical explanation that encouraged widespread use of antidepressants. While the original chemical imbalance hypothesis predated the pharmaceutical push, the industry's extensive marketing cemented the concept in public consciousness and clinical practice, creating an enduring narrative that benefits drug sales. Moncrieff urges rethinking depression not as a uniform biological disease, but as a complex, personal emotional state arising in response to life circumstances. Stressful experiences such as bereavement, unemployment, or trauma often trigger depressive feelings that vary greatly among individuals. The notion of clinical depression as a distinct medical category is problematic, given that diagnosis relies on subjective judgments rather than objective biological markers. Recognizing depression as an individual psychological reaction emphasizes the importance of understanding personal context rather than defaulting to medical interventions. General practitioners often feel pressured to prescribe antidepressants because of limited access to therapy and the expectation to provide visible intervention. This contributes to high prescribing rates, with about 1 in 5 adults in England currently taking these drugs. Despite their limited documented efficacy, antidepressants remain the default treatment, partly because they offer an apparent quick fix, even though emotional numbing and side effects may diminish long-term well-being. Moncrieff highlights that people subscribing to the chemical imbalance belief fare worse, adopting a fatalistic view that reduces their agency and hope for recovery. The discussion explores how mental health diagnoses and conditions like depression increasingly become central to people's identities, sometimes reinforcing feelings of helplessness and limiting expectations about recovery. Adopting a medicalized view can excuse feelings of failure and reduce personal responsibility, creating a victim mentality. While embracing such identities may provide temporary relief from shame, it can also hinder proactive steps toward improvement. Moncrieff underscores the importance of encouraging agency and self-examination to overcome depressive states. Antidepressants carry significant side effects beyond emotional numbing, with sexual dysfunction being particularly common and increasingly recognized as persistent even after cessation. Withdrawal symptoms from antidepressants can be severe, including emotional disturbances like anxiety, tearfulness, and physical sensations such as dizziness or electric shock feelings. Many patients mistakenly interpret withdrawal as relapse, often leading to long-term dependency. Slow, careful tapering under medical guidance is crucial, yet many doctors lack sufficient knowledge or resources to assist patients effectively with deprescribing. While antidepressants remain widely used, pharmaceutical companies have shifted focus to new psychoactive drugs, particularly for ADHD, and emerging treatments involving substances related to recreational drugs. Medications like esketamine, a close relative of ketamine, are marketed for treatment-resistant depression despite operating primarily as powerful dissociative agents with addictive potential. Similarly, psychedelics like psilocybin and MDMA are under investigation for mental health conditions, but these treatments challenge traditional drug trial methodologies, especially regarding placebo controls, and raise concerns about long-term efficacy and safety. Moncrieff distinguishes depression from other psychiatric conditions like schizophrenia, emphasizing that despite their differences, robust biological explanations are lacking for both. Mental health diagnoses rely on behavior-based assessments without objective tests, making them fundamentally different from physical illnesses with clear biomarkers. This complicates treatment approaches and public understanding, often resulting in broad medicalization of diverse human experiences under imprecise diagnostic umbrellas. Dr. Moncrieff shares how her systematic reviews and critique of mainstream notions have been met with substantial resistance from psychiatric professionals and segments of the public invested in the brain disease narrative. Some mental health advocates fear that challenging the chemical imbalance theory might discourage patients, yet Moncrieff argues that confronting misconceptions empowers people to seek change beyond pill taking. Despite growing awareness, many official resources still perpetuate outdated views, reflecting vested interests in maintaining the status quo. Recovery is often a gradual process involving self-understanding and addressing underlying life stressors rather than relying solely on medication. Therapy can help individuals process trauma, build self-esteem, and develop coping strategies, although it is not a universal solution. Lifestyle factors such as exercise, nutrition, social connection, and finding purpose play important roles in sustaining mental well-being. Importantly, most people recover from depression spontaneously over time, underscoring the resilience of human psychology even in the absence of biomedical interventions. Early research into psychedelics and related drugs raised hopes for novel treatments of conditions like PTSD and treatment-resistant depression, often combining drug experiences with psychotherapy. However, the inability to adequately mask placebos in such trials complicates interpreting benefits, and enthusiasm has extended to proposals for long-term use that risk addiction and dependency. Clinics offering repeated ketamine infusions illustrate potential for psychological dependence and ethical concerns under current market conditions. The blurring line between recreational drug use and psychiatric treatment evokes wider debates about drug policy and medical commercialization. Dr. Moncrieff cautions against abrupt cessation of antidepressants due to withdrawal risks and emphasizes the importance of slow, medically supervised tapering. Withdrawal can mirror or exacerbate depression symptoms, complicating decisions around stopping treatment. Formal guidelines exist but are not widely implemented, resulting in many patients struggling needlessly. Increased awareness among healthcare providers and patients is essential to improve management of antidepressant discontinuation and avoid chronic withdrawal syndromes. Underlying much of the discussion is a critique of societal expectations, media influence, and dominant narratives that shape public understanding of mental health. The uptake of chemical imbalance explanations parallels broader trends in medicine and culture toward seeking simple biological causes and pharmaceutical fixes. Moncrieff advocates for more nuanced conversations that acknowledge uncertainty and complexity, reduce stigma, and promote individual empowerment rather than medical labeling or identity.